I'll let Fran.
Okay.
Yeah.
Thank you. Okay. Thank you. Hi, everyone. Good morning, good afternoon, good evening from wherever you're joining us. And welcome to the MSS FPO, that's Momentum Safe Surgery in Family Planning and Obstetrics, as a webinar on supporting fistula patients' journey through the safe surgery ecosystem, marching towards 2030. And so for us, I'd like to start by welcoming you all. As people keep joining in, we will just keep going. As I see the numbers increasing. So now we're at 62, but we have a lot of people registered, and we're glad that they'll all be here and listening to us. So a couple of notes. I appreciate if you get onto this, the next slide. Information I'd like to share with everyone. And that is that in this meeting, we are having a language translation in French as well. And so if you look at the bottom of your screen, you will see the globe that is there. If you click it, it will have a French option. So we are working on French and English only for this. We apologize for Portuguese-speaking colleagues who may have joined in. Or we're working, which will be French and English. And so in clicking, you will find there that you see the French and English session, and then you also see mute original audio. So if you take your French, if you click on the French, please also click the bottom that says mute original audio so that you can hear only the language in which you click in. Thank you very much for that. If you have any questions, please pop it in the chat and we will be responding to that. Next slide, please. Thank you. So we'll just run quickly through the agenda items for today. Of course, we started off with the welcome. My name is Iyeme FM. I'm the senior global fistula manager for Momentum Safe Surgery in Family Planning and Obstetrics, funded by USAID and managed by EngenderHealth. And for this, we will be ensuring that like I said, that if you have questions, there will be a session for question and answers. And at that time, we will review your questions that you may have popped onto the chat. So if you have questions as we go along for the speakers, pop it onto the chat. And if you would like a specific answer from a specific speaker, please do pop it on the chat as well. So you have the agenda. We'll have a welcome introductions, and then we'll go on to playing a film, playing a video of that we'll be talking about later on. And so after that, then we'll go into presentations. After presentations, we'll pop in another video for you to watch, and then we'll go into question and answer session. That is when we'll be taking your questions and so on. And so we'll expect that hopefully you will be able to put in questions that people will respond to. Because of time, we will not be allowing people to ask questions directly. So if you have a question, just pop it in the chat. And in the chat, we would also be selecting, because some questions will be repetitive from other people. And so we will just answer one of those to be sure that we give enough time for all the speakers to respond to questions. And then after that, we'll go into Google messages. We have Google messages from the United Nations Population Fund, the End Fistula campaign. We have good message from International Society of Obstetric Fistula Surgeons, for short ISOP, and of course from Direct Relief. So we will be having those good messages, and then we'll go on. So for us, in going on to the next slide and inviting the next speaker, I would like to introduce one of our very great partner and funder who comes from the funding office. Her name is Erin Milke. She is the Reproductive Health Senior Technical Advisor for USAID. She will be speaking first, and after she speaks, she would hand over to Vandana Tripathi, who is the director of the Momentum Safe Surgery in Family Planning and Obstetrics, funded by USA and implemented by Engender. So please, due to the number of participants, that we will be disabling the chat and using the question and answer functions, question and answer sections only. So if you want to ask questions, please click on the question and answer sections. In view of this, I would like to invite Erin Milky to the screen. Erin, over to you.
Great. Thank you so much, EMA. And good morning, good afternoon, and good evening, wherever you're joining us. I'm pleased to represent the United States Agency for International Development as we mark the International Day to End Obstetric Fistula. Since 2005, USAID has supported efforts to prevent and treat fistula in low-resource settings around the world. USAID support is enabling the world to make enormous progress towards ending fistula. Since 2005, USAID has supported 61,017 fistula repairs in 18 countries and trained 453 surgeons and over 38,910 other health providers in fistula-related topics. In 2020, USAID awarded the Momentum Safe Surgery in Family Planning and Obstetrics project, implemented by EngenderHealth, as the flagship USAID global project to address safer surgical outcomes, including fistula. USAID, through the Momentum Safe Surgery project and other investments, continues to ensure that this debilitating condition for women continues to be addressed through mechanisms that ensure a holistic approach towards restoring dignity among women affected by the condition. We are happy that EngenderHealth has continued to sustain this approach through the USAID-funded Momentum Safe Surgery and Family Planning and Obstetrics project, through highlighting post-repair follow-up with an emphasis on rehabilitation and reintegration strategy as the final stage in the safe surgery ecosystem continuum. Ending fistula also requires cross-cutting interventions to improve women's health, strengthen gender equity, and address contributing factors like early marriage, female genital mutilation, and gender-based violence. USAID supports programs addressing all of these issues in partnership with governments and communities across the region. A lot of work has been done over the years, yet the burden of fistula remains high. With 6 years until we reach 2030, it is timely to review where we are, what strategies and approaches have worked best so far, and how we can replicate them across countries. We see that strategies that seek to interface with the government at project conception stage and a concerted effort to insert a strategy from the beginning to transition services to the governments has shown to continue even when foreign donor support ends. With approaches like these, donors can then channel funds to other areas that support the continuum of care within the surgical ecosystem. USAID continues to focus on strengthening health systems to prevent and treat fistula through partnering with key stakeholders, including governments, professional associations, community groups, and leaders, and the donor community. Together, we can achieve our goal of ending fistula. We thank all the participants today for their efforts to achieve this goal together. I will now invite the MSS FPO Project Director, Vandana Tripathi, to speak to EngenderHealth's work through the project.
Thanks so much, Erin. Good morning, good afternoon, and good evening. It's a pleasure to be with all of you today. As Erin said, EngenderHealth has worked in partnership to support women with fistula for over 20 years. This has resulted in over 48,000 women receiving surgical repairs and expansions of the key elements of capacity to treat fistula, including increased capacity for surgical repair and expanded use of catheterization to prevent fistula and treat it non-surgically. Most clients with successful fistula repairs have returned to their communities, but many have continued to experience challenges. Erin noted the interconnected nature of the interventions from communities to hospitals required to end fistula. Through our years of fistula programming, EngenderHealth has learned that a multi-pronged holistic approach comprising prevention, treatment, and rehabilitation and reintegration, all implemented as a continuum of care, is the only way to tackle and eliminate the full burden of fistula. In the current USAID-funded Momentum Safe Surgery project, we strengthen that continuum through a focus on the safe surgery ecosystem. And this includes a recognition of the external exigencies affecting a woman with fistula, beyond the fistula condition itself. Therefore, we address the first part of the continuum, prevention, through voluntary family planning counseling and services and social and behavior change interventions, including care seeking for safe motherhood services. Prevention also includes a series of clinical interventions, referral networks for early, appropriate intervention during obstructed labor, and a constellation of efforts to make obstetric surgery safe, including team building and skills improvement. However, this is only the first step towards total elimination of fistula. Treatment, the second part of the continuum, includes quality fistula repairs, medical rehabilitation, and proper counseling at discharge. Notably, the last part of the continuum, rehabilitation and reintegration, extends beyond medical care into comprehensive socioeconomic support for the rehabilitation of the whole person and her assimilation into the community upon return from surgery. In Momentum Safe Surgery, along with supporting local partners in different elements of this approach, we've also set up or joined or partnered with communities of practice, technical working groups, and movements focused on the different parts of the continuum to accelerate the global response. We hope that donors and the fistula community will focus more on this holistic approach in all three parts of this continuum to harness collective efforts by governments, community groups, and local and international NGOs to end fistula by 2030. We look forward to continuing to work with all of you in this collective effort, and thank you for taking the time to join us today. I will now invite EMA to lead the next agenda item.
Thank you very much, Vandana, for setting the tone for this meeting, for this webinar. So I will go on straight into describing our next activity before it comes on. The next one would be a video that has been nominated by WHO for an award and has been produced by one of us in the field. I'm talking about a Terewode organization led by Alice Emerson. She would be speaking to us, but first of all, let's play the video and hear what the video is about.
Abudo akiro tongino takanu nekabe. Arai beraya ite tengade ke stima mangadu michaninu. Suito setungalu ala patemu ke kesengo. Ai tengai kini kwana. Agita kini bore kere. Mabo beni kutojo. Akoni ure sudah mama ni bubo. Jai boy kini kede tonganan.
apotu tengo rengi katum na kanyari ukali lukum ni yari kedi kenyuni iko keni sodi tinge sadu munenge chwelele ad manga duko kina lostengo usemero sadu mudoranga ko ikingi atukoto ashemengo sini athiri kukun gat berai longo da mama jini ai long kukun nara apak bere ne dit ngara kinja mo jonga long koku kunye na jen na mo jongbala are chulele mo do bitu na pedra ja utu shipikun are jage ne shishe long koku jobo ni lopet.
The women are treated like social outcasts in society. The women themselves feel like they are responsible for the suffering they experience because of obstetric fistula. Fistula is more than a health issue. It's a human rights issue. It's an issue of gender inequality. It's a social injustice issues.
Ayanga potayanga songer rono to ni balati iko kepe abeite ngoda na busis na buonga doluki da chamu na kira kebera tagbela akawa chieta da yanga rangina alomuta kipitogo imame ba chwa konyeti nga twane ti mame do te karuda atiting neta konya ya ngaro na itunga
Mga pupejo kiteide mbala ara ido kwana ara lusidenga twanare ara ibo kwana yari do ade kangina parasha unembera junto be mef chulile yari teno mbala lusidenga twanare nara ara ide ngoboni
aya peta nga kaisauni duar ilo tajo kopana kapete kwana donga ai boijo do janyu akipi na bukuni kwana aurori ni na ure sunarano apakina pa isana lupa kwenyu na nge yangarango paran do di sana ngunu wala kwapo wara kwapo do de rauni tupuruchu esado munanga mupira ngina do patai kwana do ne do bere bo gbai kita kwana aluago da lailo la charo ay alama mame ne pipelida.
Well, the best way to prevent fistula is to provide access to timely and safe obstetric care. It's also really critical in their situation of obstructed labor to have access to emergency C-section and to have teams that know how to do surgeries safely so they don't get into injuries and other kinds of complications from surgery.
Buru ne chora kino nara rengo da beru ajala ne tudukon ridwenu didika kede shana kini dwerto lebe te itoriti keda dalimo na beru ngin ne dumune chulele be mame chulele yari de pedori je muke uno bongo kini bobo ja wori kapa nu chengor
Kutu chapakero na raunga bait Julai na sakero ay alama ka ajauto tunga ama musa chono tui
Yes, everyone. Thank you all very much for taking the time to watch this video. And thank you to Terry Wode and University of Minnesota for the work they've done in here. And the video has been nominated by WHO for an award. Thank you all very much. I will now go into inviting the speakers to present what they have for us. And the first speaker that will be coming on board will be the person, the founder and chief executive of Terry Wode Women's Foundation, who is also the key to producing the video we just watched. Can I invite Alice Emasu to take on the mic? Alice, you're welcome.
Hi, everyone. I bring you greetings from Terewode community in Uganda. It's so lovely to be participating in this platform this afternoon, which I think is morning elsewhere. It's interesting. The film you have just watched would have not been possible without our partners, our friends, who are committed to see that we meet the goal of ending fistula by the year 2030. I thank you all, our friends and partners who made this film possible. And thank you also for choosing this film to be part of this conversation today. I am going to particularly speak about music, dance, and drama, which is as old as Terewode's reintegration program established in 2005. The story of the two ladies, the survivors, Rose and her colleague, resonates very well with exactly what the strategist Terewode has employed in the awareness creation and advocacy, as well as in responding to obstetric fistula challenge. I will speak particularly this time on the importance of music, dance, and drama in increasing community awareness and in advocacy within Terewode's communities. Music has a way we have employed it using the survivors, and we have produced more than 20 songs and dramas, but in collaboration with survivors in different parts of Uganda, in local languages. It has been a powerful strategy towards achieving our dream of making obstetric fistula a domestic item. In other words, a word that every household resonates with. A word that every family member, be it the youth, be it the old, the elderly, the women themselves, their husbands, parents, feel comfortable to speak about. The music, dance, and drama has a very unique way it makes the survivors who participate, it makes them feel a sense of connectivity, connection. It has a way of empowering the survivors to bring their experiences, to bring their sad stories, put them together and make them and bring them out an empowered voice, an empowered collective voice on the issues that matter to them in as far as fistula is concerned. It has been used effectively in Uganda for promoting awareness and advocacy for prevention, specifically. It has a way of, apart from enabling the survivors to feel like relieved from their suffering, you know, to relieve off those sad emotions, those feelings of anger. It has a way it empowers them to feel like, you know, they're in the right space to take leadership. Although initially music, dance, and drama was a strategy that we used to raise startup capital and empower survivors to start earning income from different economic activities within their communities. It has blown up now into turning many of them as peer health educators, peer counselors, and advocates for change in the maternal health situation. It incorporates their different cultures, you know, the cultural beliefs, the cultural norms in the songs they compose. And in a way, demystifies, you know, some of those myths, the things, especially around sexuality, the woman's body, that is not talked about in public. But apart from facilitating a group of survivors to go and participate in public events like International Women's Day, International Fistula Day, and engage with different stakeholders, music, dance, and drama has also, we have also utilized it to produce radio drama series in collaboration with the media. So we collaborate with different media houses in the different communities and produce radio drama series, which are therefore played from time to time and still help to amplify the voices of survivors on especially matters of the three delays: delay to go for care, delay to access care, and then the delays at the health facilities that have contributed to some of the fistulas many of our mothers have suffered. But also now, their music captures the fourth delay, which is a delay to access treatment for care. We have performed music, dance, and drama in collaboration with different stakeholders. But there are challenges. While this is a powerful tool, we need resources. We need resources to build capacity of these survivors from time to time. There is also need for resources to purchase those airtimes for collaborations with the media. But there is also deliberate need for us as a community to promote replication and adoption of music, dance, and drama as we desire to achieve, to end obstetric fistula in our communities. It works. It requires collaborations. Thank you. And I look forward for us all to empower survivors and promote music, dance, and drama in the End Fistula campaign. Thank you.
Thank you very much, Alice. That was great. We appreciate the work that has been done. And And part of that work leads to what we'll say the next level where it would be, and that's the clinic. And it is my honor to invite an outstanding professor of urology and urogenital surgery to the screen. Professor Serene Magege, you're invited to the screen.
Thank you very much, Yeme. Thank you, everybody. Dear friends, ladies and gentlemen, it's my singular pleasure to be part of this virtual celebration of the International Day for Elimination of Obstetric Fistula. I'm Professor Soringue from Senegal, Africa, and I'm very happy to be with you today to just share some insight about what I think is very important toward elimination of obstetric fistula. We have talked about prevention. I know that this year's main topic will be prevention at the central position, but I do think that building capacity to having enough surgeons to be able to repair the patient is very important. We're doing prevention actually in all the programs to reduce maternal mortality and morbidity. We are having strong and very efficient reintegration, social and economic reintegration of the fistula patient after surgery. And I congratulate my dear friend Alice and all the other NGOs working around obstetric fistula. But we don't have enough surgeons. We are not doing enough repair. And we are just about like 6 years to the 2030 when we expected to eradicate fistula. And in this regard, we should definitely increase the number of surgeries, meaning that we should have much more people engaged in fistula surgery. The way we have done it for the past years, unfortunately, doesn't seem to me very productive, because in many countries, the doctors, the practitioners, the technicians are not really engaged in the fistula surgery activities. But we have tried to build the capacity in many countries, what maybe 15 to 20 countries, where we have been supported by many NGOs, EngenderHealth included, and UNFPA to try to build capacity. The way we did it is to run workshops. Can I have my next slides to move the slide? Maybe it's not for me. And to try to have those people in hospitals where you have enough caseloads to go and to demonstrate how to do this fistula surgery, to have the trainees themselves learn by doing. This has been the case in many countries. And at the end, the idea was not to go from one country to another and to do the work and go back home, but to build the capacity in country for the people, the nationals, to be able to do the work themselves. And this has been the case in Senegal, even yesterday and today. We're doing obstetric fistula in Mbour because of the National Urology Association meeting. And you have that in Guinea-Bissau, in Mendefera, in many other places where we tried. But the problem is, unfortunately, most of the surgeons or the doctors who attend the workshops, after the workshop, they don't translate to services the competence that was transferred to them. And many organizations, FIGO included, has tried to accredit centers, but up to date, until up to date, the fistula surgery is not taken routinely. It's usually done because experts travel from one place to another one. But this was not the objective when we started this initiative. We wanted the people in country to do the work. Like the Chinese say, instead of giving a fish to someone every day, teach him how to fish. That we have tried to do, teaching people how to do fistula surgeries. The other situation, unfortunately, is in many places, there's definitely like a scissor, meaning in some Anglophone countries, almost only gynecologists are doing obstetric fistula. In the Francophone countries, urologists are the one up front. And this doesn't help because we need all the specialists, meaning the surgeons, the obstetrician gynecologists, the urologists, anybody having a background in general surgery, work together in collaboration to take care of this. Otherwise, no single country has in Africa and in sub-Saharan Africa has enough surgeons or enough urologists or enough gynae to take care of this. So if we want to meet the goal of eliminating obstetric fistula, if you want to really increase the number of repair, all the specialists should come together and work together toward this objective. That is something very important to us. And I think ISOPS is helping. Next slide, you can move the slide, please, EMA, if you can. ISOPS is helping to have this. This, as you can move, please, move to either side, you can move. You can move. This was what I was just showing. This is, come back, the last one, yes. No, the slide before that one. Maybe we need to show, yeah, how we managed to bring, no, the one before, how we managed to bring the gynecologists, the urologists, and the surgeon at the same time. But most importantly is to put this training program in the academic setting. Not only having experts traveling and coming and going, but to put it in the standard program of obstetric and gynecology, urology, and general surgery. And instead of having one single surgeon coming in a country, we have tried with the Cote d'Ivoire UNFPA office. Next slide, please. Next, the last one, next one. To do something. We have been to Cote d'Ivoire 2 years ago. Next slide. And to work to bring at least 14 surgeons working in 5 different hospitals and training all the nationals. And after that, we have continued that experience and managed to train 10 doctors from 2020 to 2023 in December, 4 gynaes, 4 general surgeons, and 2 urologists, 2 female urologists. Now they are working on a daily basis in their hospital in Cote d'Ivoire. And I would like to thank very much the UNFPA country office in Cote d'Ivoire and the regional representative Compaore, the Minister of Health, to have supported us to initiate that experience that I think should be scaled up to reach other countries. Thank you very much for inviting me to be part of this celebration.
Thank you very much, Professor Seringe. It's always great to see you and to hear you talk. The passion you bring into this, it's immeasurable. And we are happy that you are talking about mainstreaming and continuing doing routine repairs. That is very good. Thank you very much, Professor Seringe. At this segue, we would like to see what happens to those that have been repaired. And it is here that we will invite the Healing Hands of Joy to share their experience in supporting the journey of the woman with obstetric fistula. Can I invite Elizabeth to come on to the screen? Elizabeth, you are welcome to the screen.
Thank you very much, Yemi, and everyone. And greetings to all of the participants of this session from all over the world. And I feel honored really to speak about experiences of Healing Hands of Joy, or HHOJ, in supporting women with obstetric fistula. And I'd like to thank EngenderHealth USA and all the team members for organizing this platform. I also kindly ask for apologies for not using videos. It's just to maintain the quality of the connection. I hope you understand me. Before moving to the next slide, just to say a few words about Healing Hands of Joy. It was established in 2009 as a non-governmental organization that exists to eliminate obstetric fistula, which is a preventable child health injury, by improving the maternal health care system and transforming the lives of women who have suffered. So far, we've served more than 3,000 women as safe motherhood ambassadors. As you can see on this picture, these are our ambassadors for safe motherhood and their male family members as well. So HHOJ has been contributing and will continue to contribute for elimination of obstetric fistula and other maternal health complications. So in terms of how we support women with obstetric fistula, I will mention our program components that deal with this. So we can move to the next slide. One of this is identification of new cases of women with fistula conditions. So this is done in collaboration with Hamlin Fistula Ethiopia and our Safe Motherhood ambassadors, or SMAs, who identify patients in their respective localities. And SMAs are, survivors of fistula who receive holistic rehabilitation services in our center and graduate as ambassadors. And then they become part of local structures like health extension workers and health development army that work on safe motherhood at community levels. And we also have provision of tailored trainings that enable survivors to rebuild their lives. And these include trainings on health, healing wounds of trauma, psychological life skill and IGA trainings. And besides, communication and negotiation skill practices are facilitated for our SMAs. And this is designed to enable them to unleash their potential for empowerment and make them self-contributors to their communities. And next thing is psychological counseling and trauma healing services. As you know, due to multi-layered impacts of obstetric fistula, post-surgery conditions of survivors call for psychological support to solve complications which lead to self-rejection and even suicide. So HHOJ provides psychological and trauma healing services, and besides, economic support is given because these survivors lose spousal and family support at the time. And we also do individual reintegration support and follow-up to check and ensure that obstetric fistula survivors will stay on promising track of empowerment. In addition, we have, we do support to secure support of male family members, community and state actors. As you know, male dominance affects decision-making in households. So with this in mind, HHOJ provides training and couple counseling with male family members, secure their support for their spouses, in protecting their health and exercising their mission in their communities as safe motherhood ambassadors. And besides this, we conduct separate platforms for community and state actors for their continuous support in this regard. So in implementing these interventions, we have different challenges. We can move to the next slide. We have different challenges and mitigation mechanisms. And one of the challenges is conflicts in Ethiopia, as you know, in our intervention areas. So we do context scanning and use opportune moments, to implement our program activities. And there's also continuous inflation in global funding issues. So to respond to this, we prioritize targets and we pursue proactive approaches and also use local resources, combine project activities to minimize costs, of course, without compromising quality. And the other challenge is animate humanitarian because of the conflict in Ethiopia and routes and our countries. So we have to respond to this because our safe motherhood ambassadors also highly affected by this. So we have to allocate some resources to humanitarian, even if it's not in our core program components and it is still insufficient, we are forced to consider the humanitarian support because of our SMA conflict affected, and because it wouldn't be completely unfair to leave them under difficult conditions, but they still strive to our cause, including identifying of patients. Even there are incidents even when one SMA identified more than 20 patients. So this is a very great effort of volunteerism. So we cannot leave them under these conditions. And while implementing this intervention, we join hands with different partners. We can move to them. We join hands with different partners, and one is Ministry of Health. So we do collective advocacy with Ministry of Health. We also
Elizabeth, sorry to interrupt. Please, can you speak to the mic? It's a bit low sometimes.
Oh,
Maybe.
sorry. All right. So can you hear me now?
Yes.
Louder. Okay, great. Yeah. Yes, I was talking about partners with whom we collaborate in implementing this program interventions. One of these partners is Ministry of Health, Ethiopian Ministry of Health. So we do collective advocacy with them, and we also jointly prepared National Strategic Plan for Elimination of Obstetric Fistula. And still, HHOJ is member of the technical working group to eliminate fistula at national level. And the other partners are regional bureaus, Health Bureau, Finance and Economic Cooperation. So with these actors, we collaborate to organize community outreach events like pregnant women conferences, market events, and school programs, etc. We also do joint monitoring of our interventions with these actors. And thirdly, we have Women and Children's Affairs Bureau at all levels, down to the Kabale level in our context. So we also do joint monitoring with them, advocacy, and they also involve in individual reintegration follow-up of survivors, which involves house-to-house visit of survivors to see how they are doing in terms of reintegrating with the community and in terms of using other supports we provided. And so we also they also participate in these engagements. The other partner is Hamlin Fistula Ethiopia. So we have referral services and identification of new cases. They support us in these areas, and the referral service is two-way. One is we refer patients that are identified by our SMS or by our staff to Hamlin Fistula for treatment. And then they refer them back to us after surgery or after treatment for rehabilitation and reintegration service to be provided by rehabilitation centers in 4 regions of Ethiopia. And the other partners are education and agriculture offices and district administrations. And these partners also support us in facilitating individualized reintegration, organizing school events, and assisting our income generating activity targets, women who engage in income generating activities. They support them in running productive economic engagements, and they also facilitate places where they can exercise or they can do petty trade or other businesses. So they have been of great help in this regard so far, and they'll continue to be, we believe. And there are things we should do differently to meet the 2030 targets. One is intensive and continuous awareness creation on fistula. Still, there is a lot is meeting so far. The integrity, the intensity or the level of sensitivity is not held to the desired level by our community in different parts of Ethiopia. And secondly, we need intervention on creating stronger social bond or support. And this could be, in terms of building on the existing cultural practices that endorse safety supports for pregnant and delivering women. There are just cultural things, so it's good to build on that. And we also require, for community programming, to be backed by all relevant government actors. At this point, of course, we acknowledge achievements of our governments in tackling obstetric fistula so far, and yet we recommend achievements and best practices gained from community programming, get credit, be scaled up, and made part of policy documents when applicable. And besides, multi-sector approach is needed, to tackle obstetric fistula. For example, the health sector should be complemented by the finance sectors, to deal with budget constraints that affect maternal health services. And other sectors too should contribute their respective roles. For example, if we take the education sector, if this sector, critically monitors school dropouts, the reasons, the rates, etc., it can easily find out early marriage is the main reason. So tackling early marriage is in effect tackling obstetric fistula. So other sectors too should complement the efforts of Ministry of Health or the health sector in general. And the other point is social support needed for from community structures. I think these supports can be mobilized from community. For example, there are saving schemes in women's self-help groups and other social groups, for supporting one another during mourning, for funeral services, etc. So these structures can be mobilized and used to cover transportation costs for pregnant women, at least during delivery, so that they can reach to health facilities on time.
Elizabeth, I'm sorry.
Yes?
We just need to ask you to wrap up so we can make sure all of
right,
our.
okay.
So much.
Yes, so I'll move to our recommendations to the global communities, which is one is balancing of priorities during crisis, so that maternal health is part of life-saving efforts, and recognition and redistribution of unpaid care work, so that women who with medical restrictions against laborious activities, should be relieved from these activities, and the Ministry of Women and Social Affairs should realize, the gender policy, so that women will be relieved from house chores or laborious works, including agricultural activities. And still, intensive intervention is needed to address the main risk of fistula, like poverty, malnutrition, lack of education, etc., and status of women, that expose them to detrimental health conditions. And we also need more actors in this area, especially in rehabilitation and reintegration, because there are very few of them. And we need strong partnership and collaboration and maternity waiting rooms, especially if you can show the pictures, please. 34% of maternal death occurs in Ethiopia because of the delay to reach to health facilities. Can you show the photos, please, for maternal health? Yeah, the left one is after renovation, and the right one is still waiting for support to be finished and furnished. So we also need support in these areas. Thank you for your attention.
Thank you very much, if you can hear me. Thank you very much, Elizabeth. That is really nice, and we appreciate the time you've taken to expose on that. And may I ask Dr. Kabiru Atta, the Country Project Manager for Momentum Safe Surgery and Family Planning in Nigeria, to come on the screen. Dr. Atta, please.
Yes, thank you. Thank you, Yeme. Good morning, good afternoon, good evening, everyone. So today I'll be, you've heard the speakers across each presentation. They've talked around government, how government is important for partnership. So today I'll be speaking around how to leverage this partnership for fistula programs for scale and sustainability. Next slide, please. So I think one of the things we did on the Momentum Safe Surgery project really was to do an initial assessment, looking at along the holistic fistula approach. Vandana, in our opening, talked about prevention, treatment, rehabilitation, integration. And so the idea is to say, how do we analyze and assess the key government stakeholders that we need to work with to ensure that they are part of the intervention, they are leading, and that way you can ensure scale and sustainability. If you can go back a slide before this, you will see some of the key partners, government partners, we based on the analysis, the Ministry of Health, the Ministry of Women Affairs, and the national and state obstetric fistula centers, who really are the service delivery centers, the state health and national health insurance agencies, the National Orientation Agency in Nigeria, who is responsible for a lot of government community mobilization, and the social register unit that helps to capture data around poor and vulnerable households and allows the government to be able to support them for government social and economic empowerment programs. Next slide, please. The next thing we did was also to working with government to understand where they were in terms of policies, guidelines, and plans, whether they were in the stage of development or whether they have been developed, been implemented, or were under review. And we based it based on three clear categories along the lines of prevention, along the lines of clinical or treatment, and also along the lines of social rehabilitation and integration, looking at issues around FJ, female genital mutilation, around catheterization, and looking at those cross-cutting areas such as gender-based violence, family planning, physiotherapy, and psychosocial counseling. Next slide, please. And so for some of the key action we took, we partnered with the National Orientation Agency. Please, can you go back a slide before this? We partnered with the National Orientation Agency really to build their capacity of the officials as the government agency so that their structure is able to carry out continuous community mobilization on fistula. We engage with the School of Nursing, the tutors to build their capacity to ensure that pre-service students have been taught around the issues around catheterization. We looked at the work around strengthening this standard operating protocols for management of women with obstetric fistula. And then we also engage the private sector, building the capacity of the Ministry of Women Affairs to be able to put up concept notes, to put up pitches and present to the private sector to be able to lead, which led to investment in 2 fistula centers. Next slide, please. One other area we looked at was around coordination. So we saw that there was the coordination in country was not as it should be, and then we supported to have a government-led national fistula provider network meeting. Initially, we had meetings physically, but they were becoming expensive, so we began to push them to have alternate online meetings, which can lead to sustainability beyond the project. We also began to support the state Federal Ministry of Health to push for a fistula subcommittee meeting within the National Reproductive Health Technical Working Group. In terms of data management, we know that it was important to be able to present the data in country in this visually appealing way. So we worked with the government to pilot on the DHIS, a fistula and cesarean section dashboard, which is currently in use. And we are currently piloting a national DHIS fistula tracker that allows the government to be able to see and track clients along the continuum of care. Financial support and sustainability was really important for us because we look beyond the project. How do you ensure fistula clients continue to get care? And Professor Serenge, when he was presenting, talked about how we are not seeing as much routine fistula repairs compared to pull effort. And that's because, of course, inflation is rising across most countries, but the allowances are fixed. So then the input cost of inputs are rising. So we're seeing reduction in number of fistula cases done routinely. So we began to see how do we engage the government at the budget level, national and state level to push for budgetary increase and release, engaging the national and state health insurance authorities to ensure that the fistula is considered as part of the benefit package for fistula coverage. Next slide, please. And so I want to highlight, there were several challenges, but I want to highlight one, which was really around the visibility of fistula. So of course, we felt that fistula was not really considered as being important in terms of when you look at other reproductive, maternal, newborn child health issues. And so the idea was, how do we make fistula visible? One of the things we pushed for was to see how within the National Reproductive Health Technical Working Group, which usually is overshadowed by family planning issues and presentations, we pushed for a subcommittee format, and that led to the creation and implementation of fistula subcommittee within the technical working group as well. And one other key area to highlight really was along the lines of the fistula requires partnership across several ministries, departments. We felt there was limited collaboration, and we were able to work with all partners, pulling them together to facilitate interministerial engagements. And the National Fistula Provider Network meeting was really a very good meeting point, bringing everybody together to meet regularly to discuss issues across different ministries. And that allowed us to see broader collaboration and better outcomes in the program. Next slide, please. In terms of the data for decision making, and also program implementation. At the facility level, there was really poor inter-unit collaboration. And we used the team approach to trainings, pulling in unit staff from the gender-based violence unit, the fistula family planning unit, fistula unit, bringing them together to see how they could work together. We also needed to highlight the other beyond clinical. How do we get data for patients on their other holistic needs? And so we introduced, working with the government, a screening tool to complement this clinical assessment. And this allowed the teams to be able to see firsthand beyond the clinical needs. They were able to see the family planning needs, the economic empowerment needs, the GBV needs, physiotherapy needs. And that allows the triage and the referral system to be more effective working at the facility level. In terms of data for decision making, I mentioned earlier about the dashboard, really, really helpful, very visual, and it then allowed for easier decision making by the government in around resource allocation and other issues that they were interested in. Next slide, please. And so what do we do differently? I think we need to engage more at the subnational policy level. For Nigeria and of course other countries, those subnational level, especially when you're looking at Nigeria that is a federated state, engaging more with the health insurance agency, and also investing more in pre-service education programming. So looking at the School of Nursing, School of Health Technology that produces the health workers, how do we make sure they have the right skills for doing preventive catheterization and managing basic emergency obstetric services as well. And then look where we can decentralize fistula surgical training beyond these fistula centers. How do we have a lot of teaching hospitals providing trainings for obstetrician and gynecologists? How do we make sure that they set up urogynecological units to be able to expand the fistula training program? And then lastly, linking project level trainings to recognize certificate programs that can support career progression of trained health workers. Next slide, please. And I think lastly, my key recommendation is to continue to the work around holistic approach to fistula programming, allowing us to see the big picture, identify really the critical issues, the pain points for government and their priorities, and work with them. As we know, a lot of policies and guidelines across countries have been developed or reviewed to align with the 2030 agenda. How do we, beyond the policy development that we really invest a lot upfront, how do we set aside adequate funding for policy dissemination and awareness raising for these new policies we'll be developing? How do we strengthen the linkages between fistula programs and universal health coverage programs in countries? And then lastly, continue to listen to government, their priorities, help them to refine and achieve their goals, build trust, and leverage on social capital and network. Thank you very much.
Thank you very much, Dr. Kabiru. That is really great and well marshaled. So now we'll go on to the next video that talks about the success from fistula to back to regular life. And so let's have the video playing now.
Orúkọ mi ni Ms. Michael Joy. Mo jẹ́ ọmọ bíbí ìlú Ilé-Ifẹ̀ yìí. Tó máa sọ pé mo lè ní ọmọ láyé, màá sọ pé irọ́ ni. Mo lóyún. So ìgbà tí màá deliver ọmọ yẹn nígbà yẹn lọ́hùn. Mission ni mo lọ. So ó pẹ́ kó tó di pé ọmọ yẹn ó jáde. Time ìgbà tí màá bí ọmọ yẹn sí, ọmọ yẹn ò sí. So ẹ̀yìn ìgbà yẹn ni mo discover pé mi ò lè hold ìtọ̀ fúnra lára mi mọ́, àti ibẹ̀ ni fistula yẹn ti bẹ̀rẹ̀.
Women, most of them had injury during labor. And many of them had lost a child if the woman did not die. I myself lost my mom when I was a little boy, 1 year old. I don't know if it was childbirth related, but I knew what it was, either not to have a child after labor or not to have a mother. Most of the patients with fistula were really not available in any family because they are segregated.
Ó affect ìgbé ayé mi gan-an. Iṣẹ́ tí mò ń ṣe ń gbà yẹn, mo láwọn ọmọọṣẹ́ tó pọ̀, tíṣẹ́ mi dẹ̀ tó ń lọ dáadáa. But true ìgbà tí nǹkan yẹn ti ṣẹlẹ̀, àwọn ọmọọṣẹ́ mi fọ́nká, iṣẹ́ mi dàrú, mi ò lè lọ síbi iṣẹ́. Mo máa ń jókòó nínú ilé ni mo máa ń dúró sí, torí pé ojú máa ń tì mí pé báwo mo ṣe fẹ́ park ara mi, báwo mo ṣe fẹ́ jáde síta, báwo ni mo ṣe fẹ́ ṣe láàárín àwọn èèyàn. So ó jẹ́ nǹkan tó yẹ pé ó.
Many of these patients never knew that there was a possibility of a cure. Obviously, because they thought it was spiritual, they have self-limiting prophecies that this is not curable, and they lost hope themselves. So that was a challenge. And so many of them came for care very late.
Ìgbà tí mò ń lọ sí General Hospital wa ń bì báyìí, tí wọ́n ti ń ṣe, tí mo ti ń lọ, tí kò bọ́ sí, tí kò bọ́ sí, tí kò bọ́ sí. So, ó wá dọjọ́ kan bí dókítà kan ṣe pè mí nìyẹn pé hello, ṣé mi ni Michael Joy? Mo ní bẹ́ẹ̀ ni. Wọ́n á sọ fún mi pé kí n máa bọ̀ kí wọ́n rí àwọn ní hospital báyìí báyìí o. Pé nǹkan tí pé surgery tí mo fẹ́ ṣe tí kò bọ́ sí lọ́dọ̀ àwọn bì báyìí o. Pé wọ́n fẹ́ ṣe fún wa ní free. Pé kí n máa bọ̀ ní Wesley Gid, Iléṣà.
The patients could not pay for services, they couldn't pay for the care they needed. And therefore you find that, look, you want to do something good for someone who required it, but the system did not permit that to happen. So it is like you are helpless yourself. You needed help to be able to help someone else. And the federal government also promulgated that, or at least decreed that fistula patients should be cared for free in federal government facilities. The extent to which that is being implemented varies from place to place.
Bàtà débẹ̀, arọ́pọ̀lọpọ̀ èrò tó pọ̀. So ó wá jẹ́ kọ́kàn mi gan balẹ̀ pé ṣé pé èrò pọ̀ nínú nǹkan yìí tí nǹkan yìí ń ṣe. So àyà mi ti ń já tẹ́lẹ̀ already pé bóyá ogun ayé ni. Bọ̀gbà tí ó ti rí bẹ́ẹ̀ yẹn tí mo ti rérò tó pọ̀ lóríṣiríṣi, ó jẹ́ kọ́kàn mi balẹ̀ pé Ọlọ́run máa ṣe ogun ayé mi níbí báyìí. Nígbà tí wọ́n parí iṣẹ́ abẹ yẹn, ohun ìdùnnú, ayọ̀ ló jẹ́ fún ọkàn mi àti ohun tuntun ló dẹ̀ tún ṣẹlẹ̀ nínú ìgbésí ayé mi. Ìgbà yẹn lọ́hùn, téèyàn bá fẹ́ jáde, a máa faṣọ páàkì ara ká tó jáde, kéèyàn máa lo pampers ká tó jáde, bọ̀ kò sí nǹkan tó jọ mọ́ bẹ́ẹ̀ mọ́. So mo wà free, mo lè sùn bó ṣe wù mí, mo lè ṣe bó ṣe wù mí, mo lè rìnrìn pọ̀ pẹ̀lú àwọn èèyàn, mo lè travel, mo lè bá àwọn ènìyàn sùn pọ̀, mo lè bá àwọn èèyàn ṣeré pọ̀. So ó jẹ́ ìdùnnú àti ayọ̀ fún mi, inú mi dẹ̀ dùn torí pé Ọlọ́run ṣẹ́ ogun ayé mi.
The effort of governments and interested Nigerian philanthropists has also attracted international organizations, particularly EngenderHealth. Particularly EngenderHealth has done so much to help programming for fistula care in Nigeria. The same thing with UNFPA, United Nations Population Fund, and also USAID.
Àwọn tí Ọlọ́run lò fún mi láti ṣiṣẹ́ yẹn, nǹkan tí mo lè ṣe jù ni pé kí n dúpẹ́ lọ́wọ́ wọn pé wọ́n ṣe. Pàápàá jùlọ Dr. Fẹ̀yìntọ́lá, wọ́n ṣe gudugudu méje àti yàyà mẹ́fà fún mi. Mo dúpẹ́ lọ́wọ́ wọn. And then àwọn tó gbé iṣẹ́ tó gbé ètò yìí náà kalẹ̀, àwọn EngenderHealth, mo dúpẹ́ lọ́wọ́ títí wọn náà tí wọ́n bá mi tán jẹ́ kí ìṣòro ayé mi kó di ìgbàgbé. Mo dúpẹ́ fọ́kọ tọ́lọ́run fún mi torí pé ó wà pẹ̀lú mi, ó dúró tì mí, kò ti torí pé nǹkan yẹn ṣẹlẹ̀ kó wá sọ pé òun ò mọ̀ mí rí mọ́, tàbí pé kó sá lọ, tàbí pé kí n má rí mọ́, bọ̀ wá jọ wà, adẹ̀jọ́ ń gbé. Ọ̀pọ̀ ọ̀gá gan nígbà míì tí n bá fẹ́ sunlẹ̀, á ní kí n má sùn sílẹ̀ pé kí n máa bọ̀ lórí bẹ́ẹ̀ kí n jẹ́ ká jọ sùn. So mo dúpẹ́ lọ́wọ́ Ọlọ́run fún ọkọ tí Ọlọ́run fún mi.
Kì í ṣe ìbànújẹ́ la fi bẹ̀rẹ̀ relationship mi ò wò nítorí pé fistula problem ó ti wá wọ̀ ẹ́ pé kí wá filẹ̀ wọn pé láyé sàwọn ọ̀rẹ́ mi sábà mi jà lóríṣiríṣi pé kí ni mo rí lára ẹ̀ gan pé mọ̀ wọlé kò lè yé ẹni tó bá ní ìbẹ̀rù Ọlọ́run á mọ condition tí ẹnì pa kì í ṣe ìdùnnú pé kó wà nù condition yẹn but nígbà tí gbogbo ẹ̀ sáà ti jọjú ta ti ṣe everything tán àṣà àgbàgbọ́ lẹ́yìn ìgbà náà la bímọ àbí ọkùnrin àbí obìnrin.
The global initiative is to see that all cases of VVF are eliminated by year 2030. And that is just in 9 years to come away. One of the greatest things to do is to ensure that no woman goes through prolonged obstructed labor. We know that is the commonest cause. And labor becomes obstructed when nobody skillful attends to it, attends to the woman. I want to let all women who are living with fistula to know that they are loved, they are wanted, they have friends, they have families. They should appreciate that life comes with challenges. And the best way to overcome challenges is not to run away from it. Since you know there is a cure for fistula, they should be strong in their will, make up their mind to visit a healthcare provider nearest to them to seek advice on where to access care for fistula.
Yeah, thank you very much, those who watched this video, courtesy of USA Momentum Safe Surgery and Family Planning Project. We're going to get into question and answer session now. And we would like to remind ourselves that if you have questions and things, remember to pop it in the Q&A section, not in the chat. And the questions that have already been asked. And so I would invite Dr. Kabiru Attar to take on one of the questions, and as we go through and identify which speaker will address the next question. Dr. Attar.
Okay, yes, thank you. Thank you so much, Yeah, I think it's a question around how can we address the issue of awareness among young medical practitioners in terms of diagnosis and prompt referral of patients to the fistula surgeon. So really excellent question. And if you look at it, the young medical practitioner oftentimes is graduates from school and is expected to go to the hospital and begin to carry out cesarean section sometimes with really no skill set to do this. And what that means is that we're exposing a lot of women to iatrogenic fistula due to some of the complications. It also means they are not aware around some of those preventive practices where you have to identify, use the pathograph and refer the pregnant women for appropriate care once there's an obstruction. And even the simple procedure as inserting a catheter sometimes is missed. And so what we are doing is in Nigeria, we've worked with the government to develop the National Training Manual for medical doctors and nurses, inclusive, on fistula management, which really is all-encompassing and addresses these issues around fistula care, catheterization, and now looking at issues around improving cesarean delivery services. And we've seen massive improvements. We were just analyzing some data recently from two states we worked, Sokoto and Kebbi, where we had done training on cesarean delivery for about 21 days for young doctors, and the cases of iatrogenic fistula were completely not seen, and so the government needs to continuously begin to invest in this, making sure we are working with the national medical associations, the national and medical nursing councils to imbibe these trainings around fistula, around cesarean delivery, and within not just the young medical practitioners, but also the nurses and other health workers as well. Thank you, Yemi.
Sorry, I was muted. Thank you very much, Dr. Kabiru. I'm sure that Babagana Fatima would be very happy with that answer. And of course, Dr. Kabiru is available to respond more to the question. There's another question on here I'd like to invite Alice Emerson, if you're there, to please take the question. Please, where can we get resources to integrate music, dance, and drama, and to also bring fistula clients together for social gatherings and more awareness creation and ending obstetric fistula? Thank you. Alice, if you're there, if you're still with us, please go ahead.
Hello.
Oh yeah, go ahead, Alice. We can
Yes,
hear you.
Well, the resources, it sounds like really a huge challenge, but I just would like to inform you that the former fistula patients, the survivors themselves are a key resource for performing music, dance, and drama, promoting music, dance, and drama, even in those hard to reach areas. The survivors are a huge resource. And then the media sector, they are local available resources for that, but then the financial bit of it is where we need our partners to come in, because those local, the survivors themselves cannot fund, because they need transportation and you need training them, before they can go and perform. Then you need to record the music, or their songs, their drama, you need to record them, and in local languages. Well, the local languages is where how they act, but you need to record it and probably translate it also in English if you needed to target an English community. So we'll still need to call on our partners who have been committed, and EngenderHealth, UNFPA, I can't name them, to continue supporting us, because this is a powerful strategy. Thank you.
Thank you very much, Alice. And I would also recommend Pogna Rosemary to check on Terewode website and to get a wealth of information to support them. There are more questions coming on, but we will need to move on to the next and invite for goodwill messages. So we will start by inviting our next speaker on the goodwill message. Can we have a change of slides? Yes, thank you very much. So we have a goodwill messages from key partners and also from coordinators of Fistula in different areas. I'll start by inviting UNFPA, Bridget Asiama, who's the person managing the End Fistula campaign or coordinating the End Fistula campaign for UNFPA, to give a goodwill message from UNFPA.
Thank you very much, Yemi. Thank you so much. Good morning, good afternoon, good evening, dear partners and colleagues. I extend warmest greetings to you as we have convened today at this very important webinar on the topic of supporting the fistula patient's journey through the safe surgery ecosystem. I would say thank you so much to the presenters, Alice, Professor Gay, Elizabeth, Dr. Atta, for your presentation, your insights, and the recommendations that you've given so far. These have been very helpful for our work on going forward on fistula. I am privileged to give this goodwill message on behalf of UNFPA and the global campaign to end fistula. As we commemorate the International Day to End Obstetric Fistula upcoming May 23rd, the day which is instituted by the UN to raise awareness, intensify actions, strengthen partnerships, and mobilize support towards ending fistula within the broader context of improving maternal health in general. In 2018, as we are aware, UN member states called for an end to fistula by 2030, recognizing that this was a public health, development, and a human rights issue. The timeline to 2030 draws closer and closer. We just have a few more years to get to 2030. The theme for this day, 2024 International Day to End Fistula, is breaking the cycle, preventing fistula worldwide. It's a call to end the condition by preventing its occurrence in the first place, which will consequently break the harmful cycle of ill health, intergenerational poverty, and social marginalization. As we heard from Professor Ojengbede, who rightly said no woman should go through prolonged obstructed labor. We are aware that apart from obstetric fistula, there are other childbirth injuries that occur when a woman goes through prolonged obstructed labor. Over the past 2 decades, UNFPA and campaign partners such as USAID, EngenderHealth, Terewode, ISOBS, Direct Relief, Healing Hands of Joy, and many others have tirelessly worked to end the condition. Today, as we have gathered virtually from different corners of the globe, UNFPA acknowledges the power of unity and collaboration in our shared mission to address the challenges faced in fistula prevention and response, and those faced by the fistula survivors. The journey of a fistula patient is challenging, yet woven within this narrative are threads of resilience, courage, and hope. Support for every woman and girl who goes through this journey should be holistic, tailored to enhance her quality of life, agency and dignity, and contribution to her community. At UNFPA, we are unwavering in our commitment to lead the global campaign to end fistula and ending preventable maternal deaths and morbidities, which is one of our 3 transformative goals. Our comprehensive approach encompasses health system strengthening in countries, innovations to ensure timely access to quality care, including development of emergency obstetric and newborn care facility networks, which optimizes function of the facilities and ensures travel within 2 hours. Strengthening midwifery education and provision, service provision for quality of care, including at the primary health care level. Enhancing access to family planning services and contraception, as well as strengthening capability and availability of services for fistula repair, rehabilitation, and social reintegration. Notwithstanding, not forgetting our global programs to end child marriage, and then enhancing gender equality and human rights. To date, UNFPA has supported 23 countries to develop national fistula strategies, recognizing that country ownership and leadership is key if we want to end obstetric fistula. We've also supported the establishment of government-led fistula tax teams to monitor and coordinate programs in countries. To date, nearly 140,000 fistula repairs have been directly supported by UNFPA, and the reintegration of over 15,000 fistula survivors also. 14 countries have developed IMONG facility networks, and over 550,000 midwives have been trained with UNFPA support, including training on prolonged obstructed labor. UNFPA will this year launch its first corporate maternal and newborn health and well-being strategy, and also launch the phase 4 of our flagship maternal and newborn health program, with an enhanced focus on building resilient health systems, and a focus on quality of care, including for safe and essential surgery to prevent obstetric fistula and iatrogenic fistula, and also ensure timely treatment for fistula survivors. Also, the focus would also be on policy and accountability and meaningful community engagement. Thanks to our collective efforts, more fistula patients are receiving care and the support they need. Communities are becoming more aware, and stigma is being replaced by understanding and compassion. However, our work is far from over. The journey towards ending fistula requires sustained dedication, collaboration, and coordination among multiple sectors and borders, and even more so in crisis-affected regions. It demands innovative solutions, increased investment, data and research, and above all, a renewed commitment to leaving no one behind. In September this year, the UN Secretary General will present his biannual report to the General Assembly. UNFPA and the campaign is also leading the development of a global roadmap to end fistula, and this document is expected to accelerate actions and provoke investment to end fistula. Let's continue to amplify the voices of women and girls living with fistula. Their experiences, insights, and aspirations must guide our actions and policies. By centering their voices, we ensure that our interventions are truly responsive to the needs of those most affected. UNFPA stands in solidarity with USAID, EngenderHealth, and the many partners in the global campaign to end fistula, to improve the lives, dignity, rights, and well-being of women at risk, living with or recovering from obstetric fistula. I wish to express our deepest gratitude to those who tirelessly champion the cause of fistula patients, from healthcare workers on the front lines to advocates, including our fistula survivor advocates, policymakers shaping policy agendas, and program managers. Your dedication is an inspiration. Together, we can ensure that fistula and other childbirth injuries become relics of the past. Thank you.
Thank you very much, Bridget. Atiama, that is very good, and we appreciate the perspective shared and the goodwill message. At this stage, I would like to invite Direct Relief to give us the goodwill message. May I invite Paulina to take on the screen. Paulina, please.
Thank you so much, Yeme. And thank you to all of you for joining the call today. It's been really wonderful to hear all of the commentary and recommendations for how we move forward over the next 6 years. And I want to take the opportunity for Direct Relief to highlight some of the contributions that you as members of the fistula community have made in efforts to eradicate obstetric fistula. Last year was the 12th year that Direct Relief distributed the annual Fistula Repair Survey, which gathered self-reported data from 163 fistula repair facilities across 34 countries. Together, these facilities conducted 19,434 fistula repairs in 2022, marking the highest number of repairs ever reported in a single year. The significant participation of fistula repair facilities contributing to this record-breaking report count is rewarding to witness, to see the growing number of facilities engaging in data sharing, aligning with the survey's objective of fostering data exchange within the fistula repair community. Overall, since we've been doing this work with the survey since 2010, Direct Relief has captured data from 153 repair facilities who in aggregate have repaired almost 124,000 fistulas. We believe that this represents the largest data set on fistula repairs worldwide and have a deep appreciation for all the surgical teams who take the time and the effort to report on their fistula repair activity. More importantly, each of these 123 plus thousand surgeries captures represents a new chance of life, for life with dignity for each of the women that are touched. And although I recognize that not every surgical repair is repaired at the first go, each of those 123 surgical touch points represents a woman who was found, identified, and referred to care by the teams working on obstetric fistula. This data is collected for the benefit of the fistula community, and I want to reinforce and remind everybody that it's available to you as surgeons to contribute to, but it's also available for academics, advocates, and others to download, to use, and to share. The data can be visualized and shared at www.globalfistulahub.org. We'll put that in the chat for you, along with other relevant open data sources that can be combined with the fistula repair data, along with academic publications, and also with survivor stories. So I encourage all of you to share and use this resource and explore that to see how you can integrate that into some of the tools that you're using to communicate about the work around obstetric fistula. As Direct Relief moves into 2024, we hope to continue to contribute to the work by supporting surgical facilities who are doing high volume fistula repair, who are doing it on a day-to-day basis. And we hope to support them with the surgical consumables that they need for successful surgical repair. In 2024, Direct Relief will be shipping fistula repair modules to our network of fistula facilities containing enough consumables, medication, and suture to support 7,500 fistulas, or rather the repair of 7,500 fistulas, which will be our largest year of support to date. In aggregate, we estimate that since 2013, Direct Relief has provided material support for approximately 39,000 surgical repairs. So we commend you for this work. We know that it's difficult and it's often done without proper reimbursement, but it's done with the passion for doing what is necessary for those who need it most. Direct Relief is in awe of what you do, and we thank you for it. Back to you, Yeme.
Thank you very much, Paulina. That was a great recap of what Direct Relief does and how we're able to tap into that. And we're happy that you have this year your best approach to repairing more women with fistula. This is great. Thank you very much. Yeah, I will at this stage talk about, I'd rather invite ISOF's president on the screen and ask that she's not available on here, but she did send in a recording and asked us to play for the benefit of the people who are there. She's a fighter in the area of fistula, and we invite her to, let's listen to her speech.
Hello everyone, I am Professor Saib Akhtar, President ISOPS. On the occasion of the International Day to End Obstetric Fistula, I want to congratulate the entire fistula community who have devoted themselves to serve for this noble cause. I would like to thank USAID and EngenderHealth and
Please, can you increase the volume, please?
2024 to 2030, only 6 years to go with huge task ahead. Though the number of fistula has been declined, but still it is happening. In addition, burden is the increased trend in iatrogenic fistula. Considering this scenario, we need to intensify our actions. The collective effort of clinical practitioners, community implementers, government partners, international organizations, all together can bring the desired result. The theme of supporting the fistula patient's journey through the safe journey ecosystem is really a time-demanding concept. The access to optimum quality full obstetric care is every human's right, which must be ensured. There should also be a safe surgical ecosystem available if any woman needs it. This is the basic concept of prevention of fistula. ISOPS has been working since long for the cause of fistula. All the world's famous fistula surgeons, including urologists, obstetrician, gynecologists, and other surgical specialists, have come under one umbrella in this organization, and this gives an immense strength to our morale and also to our work. We have a good number of fistula surgeons who are originally obstetrician and gynecologists. So this puts an extra strength to our work because they can work to improve and optimize the obstetric care services that will help to ensure good obstetric care and prevent obstetric fistula as well as iatrogenic fistula. ISOPS is also working to improve the awareness and training on safe surgical practices so that young fistula surgeons on fistula surgery, and also to arrange accreditation of some centers. This will help to increase the number of skilled fistula surgeons who will be able to contribute more effectively in fistula elimination. ISOPS has also been working with local government to create awareness for prevention of fistula. Last but not least is the rehabilitation and reintegration of the fistula survivors in the community. Those who get cured must be reintegrated and rehabilitated in society. On the top of that, those who suffer from persistent fistula-related disorder have a different spectrum of rehabilitation needs that must be addressed meticulously. I once again want to congratulate the organizers for highlighting all these issues in this webinar. On behalf of ISOPS, I want to give my word that ISOPS will continue to work for the cause of fistula. This year's themes of International Day to End Obstetric Fistula is breaking the cycle, preventing fistula worldwide. Indeed, the only way to break the vicious cycle is to stop fistula from happening. So our utmost effort should be prevention of fistula. As the president of ISOPS, it is my appeal to all of you, we must work together so that we can conquer the battle of fistula elimination by 2030. Thank you all.
Thank you very much. And that was from Professor Sayeb, the president of ISOPS, International Society to End Obstetric Fistula. So we have come to the end of our webinar, and I'd like to say obrigado, Ingiyabonga, Amsegnalo. Dalo, thank you all very much. It's a great meeting. For those who had questions in the answer, in the chat or in the question and answer session, please take note. The answers were responded to, and we will do our best to try to reach out to you specifically if there are additional specific questions. This proceedings have been recorded. It will be on the web once it is ready, and everybody who participated will get a link to the web so that you can follow up and hear some more if you want to. Thank you very much. I'd like at this stage to thank the presenters.
Yeah, thank you so much.
Thank you, the presenter. Merci beaucoup, Professor Seringe. Thank you, Elizabeth. Thank you, Alice. Thank you, Dr. Kabiru. This is very, very nicely done. Thank you all. We appreciate. And of course, USAID, UNFPA, Direct Relief, who all participated and from the beginning and listened to up to the time when your speech was made. We appreciate your patience with everybody. And then those who are in the background that you never see, Afrisha, Tyler, Sarah, Karen, that we bear the same name today, Karen and Vanden, of course, and Renee. We want to say a big thank you to everyone who has made it possible for this to happen. We give God the glory. Thank you all very much and have a good day. Bye-bye.
Thank you. You too. Bye. Thank you.
Thank you.
Thank